Good afternoon. I am Melissa Toledo Ontiveros with Constellation Consulting. We are pleased to present the New Mexico 2021 Summit on Health Equity. The summit is funded by the New Mexico Department of Health Tobacco Use Prevention and Control Program and will take place throughout May on our event app with live sessions each Wednesday afternoon. For more information about the summit, please visit our website at newmexicohealthequity.org. Due to COVID-19, this year's Summit on Health Equity remains online, and we appreciate those who have participated and supported this year's event, including the New Mexico Department of Health, our Summit Planning Team, Presbyterian Healthcare Services, Conalma Health Foundation, Be Well New Mexico, the Santa Fe Community Foundation, and others. For a full list of supporters and online exhibitors, please visit our event dashboard online or on the Whova app. I also encourage you to utilize this year's Summit on Health Equity event app. The Whova app provides you with opportunities to network online, schedule COVID-safe meetups, create discussion groups, visit our exhibitors and supporters, watch recordings of sessions you may have missed, download files provided by our presenters, and more. It is a great tool for you to use not only during our live sessions, but also throughout the month of May. Plus, when you use the app, you can earn points, which could mean prizes. Please click the leaderboard on Whova for more information. For our session today, attendees' webcams and microphones have been disabled. If you have a question for today's presenter, please use the Q&A function within Whova, and we will address as many questions as time allows during Q&A. Also, any materials provided by today's presenter will be posted as part of this session within the event app. Following today's session, we appreciate if you take a few minutes to complete our session's feedback by clicking right in this session of the Whova app. If you'd like to request community health worker or social worker CEUs or continuing medical education units, please include your name and email address on your evaluation, and CEU certificates will be emailed within 60 days. If you need assistance with CEUs, please email us at info@constellationnm.com. If you need assistance during the session, please utilize Q&A feature or the Ask the Organizers feature in Whova. You may also try emailing us directly at info@constellationnm.com. And finally, before we begin today, Constellation Consulting acknowledges that our organization operates primarily on the unceded ancestral homelands of the Tiwa-speaking peoples. Racism has no place in our communities. Constellation Consulting and our team members are committed to racial equity. We acknowledge and denounce the violence and discrimination affecting the Black and Asian and Pacific Islander communities, with whom we stand in solidarity. We are New Mexico, and we are built strong by the diverse people of our communities. There are a variety of organizations supporting health equity throughout our state. We have listed just a few here and encourage each of you to seek out, learn more, become involved with, and support organizations who are building a better New Mexico for us all. Today, we are excited to host Dr. Laura Parajon, Deputy Cabinet Secretary for the Department of Health. Dr. Parajon is on leave as Executive Director for Community Health and Assistant Professor, Department of Family and Community Medicine at the University of New Mexico. Dr. Parajon has served in a variety of community-based positions, including Medical Director for the City of Albuquerque's COVID response for people experiencing homelessness, Medical Education Director for the Community Health Initiatives, and Executive Director for Community Health at UNM. You can read all of our presenters' complete bios in our event app and on our website at newmexicohealthequity.org. Please welcome Dr. Laura Parajon.
Thank you very much. Thank you for the introduction, the kind introduction. I'm going to be sharing today here on health equity from the Department of Health. So let me just make sure I can get that, pull that up. Sorry, I had that before. Here we go. Okay. Great. All right. Hi, everybody. Thanks so much for joining us today. I'll be sharing about the equity plan at the center of New Mexico's COVID-19 vaccine response. Please feel free to put any questions that you have. I just want to share a little bit about what we're doing and then answer any questions or engage in any dialogue. So I'm going to provide some of the basic understandings of the logistics involved with distributing COVID vaccines throughout our state, provide an understanding as to how the state is supporting vaccine distribution to New Mexico's priority populations, and provide an understanding of the activities that the state's utilizing to build trust with individuals and communities to accept the vaccine when it's available to them. And I know that Dr. Will Darwin will be speaking more about IHS's equity efforts. So I'm just so grateful that we're in partnership with IHS and many partners throughout the state to do this work. So I'll go over some of the key elements of our equity plan here. We have 4 components of our equity plan, and that is equitable allocation and access of the vaccine. And I'm sure that Dr. Darwin will be talking more about how they've done it at IHS. The organizational structure and communications that we put together for the vaccine equity plan, community engagement to build vaccine confidence, and then monitoring and evaluating for equity so we actually know how well we're doing on this response. So, we know that certain populations were disproportionately affected by COVID, and that is on our Native American populations, our Hispanic Latino populations, and African American populations. So as well as our older population. So how do we operationalize then, if these groups are the most disproportionately affected, how do we operationalize how we care for these groups? So I'll go over how we did it at the DOH, equitable allocation and distribution access. What we did was really think about the whole process in 2 ways. Both the community level approaches and individual level approaches to how we save lives and stop the spread of COVID. So at the community level, we were looking at how do you save lives at a kind of community level. So that's where we used, looked at vulnerable population and communities. So it's a community approach to addressing where we're putting vaccine in higher SVI communities and in congregate living settings. Also, the other way to save lives was really approach trying to address who were the higher risk individuals, meaning those with higher age or people with COVID with illnesses that put them at risk for COVID. So that was one way we looked at how to do this work. The other way we looked at it was how to stop the spread. So, putting vaccine in places with a higher community rate of infection by looking at certain zip codes that had been disproportionately affected was the way we also helped target some of our vaccines. And then the second thing we looked at was, the higher rate of individual exposure risk, healthcare workers, essential workers. And so essentially thinking about these in 2 buckets, right? Saving lives and stopping the spread at both the community and the individual level. So we used the equity allocation framework from CDC and the social vulnerability index, which is an index that comprises of 4 main groups of overall vulnerability. And then within each of these groups, there's smaller pieces of what puts someone at risk. So, you have socioeconomic status, household composition and disability, minority status and language, and housing and transportation. these are organized by counties as well as by zip codes. So when we look at the social vulnerability by county, 1 is the highest social vulnerability and 0 is the least amount of social vulnerability. So if you look at the map here, there's certain areas that had higher social vulnerability index. So what we did was allocate 2 ways initially, and we're talking about before when we didn't have as much supply and we had higher demand when we were prioritizing by phases. We were looking at allocating in areas of high SVI so we can reduce morbidity and mortality, and then allocating in areas of high cases, which is places to reduce the spread of the virus. So our team as a whole would look at, where we should be placing the limited vaccine we had so that it would help people who had been disproportionately affected by COVID. In order to ensure allocation to highest risk individuals, we were looking at the phased guidance. So that's why we went from 1A to 1B to 1C, looking at using the ACIP guidelines around, giving to people who are long-term care facility residents and people who are older, 75 and older, 16 and 64, and then person 60 to 74 years old as the highest risk individuals. And it took us a while to get through a lot of this group, and then also allocating to people who are the highest risk individuals, had the most exposure. And we're still doing that. We're still prioritizing that group, but there's just so much more supply that we can essentially give it to anybody who wants vaccine. However, we're still working, at the DOH to say, okay, for the older people, we're still doing homebound vaccines. We're still trying to get seniors in. We're still trying to work with now essential workplaces to see if we can get those people who are, at highest risk vaccinated. The other thing we've been doing is to try to work with equal access. So we knew that there were some areas, especially rural areas, that had difficulty getting vaccine because they were just didn't have providers nearby. So we worked together with the local, regional directors from our, public health department, and also community organizations to get some of these mobile vaccination teams in. Work with community health workers, especially in the Southwest. Public health department did a lot with community health workers. And also we now just started walk-in clinics a few weeks ago, and that's really helped. The other piece that we did that that people may not know is that we had to develop, since we were just getting more and more complexity on the vaccine piece, we developed an organizational structure and communications for equity. So one of the things was we made a little mission for the vaccine so that everyone could be aligned on what we were trying to do. So really put equity first. So we did equitable distribution of the COVID-19 vaccine to decrease morbidity and mortality from COVID-19 and preserve societal function. And then, our communications theme was vaccinate New Mexicans swiftly, efficiently, and equitably to save lives and stop the spread of the virus. So that was just what we would share all the time at press conferences that the Secretary of Health, Secretary Collins, would do. The other thing we did was really organize our structure so that in our ICS structure, which is the normal incident command structure that most people do for disasters, we reframed our incident command structure to really focus on SMART objectives that were equity based. So what were objectives that would support the mission, the equitable distribution of the mission to decrease morbidity and mortality and preserve societal function? So we had a unified command that was comprised of different departments across the state, including our Department of Health, and then other representatives from Department of, the Department of Homeland, DHSEM security and emergency management, so that they could help us with some of their staff. And then we formed a joint information center. So information was similar going up and down, both internally and externally. And also made sure we had a community vaccine equity task force to kind of guide some of our equity pieces. We also made sure that we had a clear operations section that focused on equity, a planning section, and then logistics and finance. So there's a lot of things that went into trying to make sure our structure was good for equity, because I think equity isn't just about doing equity, but it's also organizing for equity. This is how we updated our operations section. So when we started seeing that there was a slowdown and we needed to reach out to more communities, we heard from communities that they needed to have sites closer to them. And we knew that it was difficult to get to different groups. You needed to have different strategies. We actually, updated our operations section to include a whole section on mobile teams, and then also a whole section that just responded to specific groups, so that we could coordinate better with different groups who are asking for a vaccine, like people, school-age children and colleges, corrections with jails and prisons, people experiencing homelessness. So we actually ended up having a person who was event scheduling and just opening up right now the ability for groups to ask us for mobile teams. So a lot of work going on. And then the health equity response branch, which really is trying to make sure programmatically we're looking at things not just right now for vaccine equity now, but also looking at equity long term. The other piece that we really worked a lot on was community engagement to build vaccine confidence. And really, this is long haul work, right? Even though it's vaccine equity right now, it's the work we need to do to continue to build foundations of trust in the community. So the part of the way we're building the vaccine confidence is really reinvesting in our health promotion infrastructure that we do have at the DOH. I know one of our health promotion managers are here today, but basically we asked the DOH team, what did we need to kind of build for vaccine confidence and build trust? And it was to really rebuild. There were some staffing positions missing for health promotion managers, as well as for the specialists. So we invested in that, as well as investing in health councils and tribal health councils and community and faith-based organizations to try to work together to identify barriers and facilitators for COVID-19 vaccine uptake, to support local communication plans and strategy, train networks of CHWs and CHRs to communicate messaging in local and tribal communities, and deploy CHWs and CHRs in areas with high social vulnerability index, including door-to-door home visits, and support of local community pods for vaccination. So that's kind of our big picture of how we are trying to approach this. The way it looks like or operationalizes in terms of vaccine demand generation is that we haven't implemented all of it. We don't have all the funding for it, but we're putting the pieces together. So right now we have our DOH health promotion and health equity team, and we're slowly building up to be able to support community health councils and more community orgs. And the idea is that if we can train and support community health workers and CHRs in each of these SVI communities, they can do activities like rapidly assess like how well we're reaching the people who need to be reached. What kind of key messages are we sharing, and can we adjust and adapt community plans that then they can share with the Department of Health to try to improve the equitable distribution piece. The CHWs and the CHRs can go out to the communities, continue to build on the trust they have, share those key messages, and help support the community plans, and really reach different groups, churches, and different groups at churches, at community events, through town halls, through multiple different ways, so that on this side here, you have the vaccine demand generation, and then on the other side, DOH with the equitable distribution the DOH equity team supporting these community plans, like you saw there, like a community event coordinator trying to link in, what communities are asking for with what our teams can support with in terms of mobile teams, prioritizing people who are providers at-risk communities, and then trying to increase our evening and weekend hour capacity, because that's kind of what we've been hearing from the communities. So we think that if we can increase the vaccine confidence and demand for the vaccine, and then meet people where they are, we can improve our vaccine equity in the state. And I'm going to just show you some examples of what that looks like already. So we're using the data. So that's really important. Without the data, we don't know where we're going or if we made a difference. So we're collecting and tracking data. We had to actually increase our equity team, evaluation team, by 5 people. We got support from FEMA and from National Guard, and also our own team at the DOH, to be able to track the county's age, race, and ethnicity for receiving the vaccine. So every week our team looks at the data and says, okay, how are we doing on seniors? How are we doing on African American, on Latino, Hispanic, right? Native American, we know that IHS is taking care of that piece and doing excellent on that piece. We only have 3 Pueblos who signed up with us, and they also got vaccinated really pretty quickly. Then we provide county level data on the public vaccine dashboard. We monitor vaccine coverage in areas of high social vulnerability or high COVID cases. And then we're sharing that data back through our regional directors, and our emergency managers get the data every week as well. So what we see now is that we've been able to vaccinate then 60% of New Mexicans have at least 1 dose, and then 48% are fully vaccinated. But does that mean we got vaccines in people who were most, disproportionately affected? And that's where our equity data comes in. We have data on this is all from our website, where you can see percent of people vaccinated by county. So that's good. You can just hover over your county and it'll tell you how much your county has been vaccinated. We also have data on how many people who've been fully vaccinated, 65 and over, 40 to 64. So you can see that we really focused a lot on 65 and overs first. And so you can see we have a very high percentage of people vaccinated over 65 years of age. So that's been good. So you can kind of see where we're at every week. And then actually this is updated daily, Monday through Friday. So you can see how we're doing. Here you can see how we're doing by race and ethnicity. We did really have to work with IHS to coordinate the data for American Indian population, but the other populations we had through our immunization system. So you can see how well each group is doing. And then here is another view. This is a view that's basically the view of people who are distribution of first doses by race or ethnicity. So it's compared to the share of the population. So you can see that even though we actually, I don't know if you know this, but if you look at this is a link to the Kaiser Family Foundation data on race and ethnicity doses in the state of New Mexico compared to the rest of the country, or you can, any state can look at it. New Mexico is actually one of the top, top highest equity doses for Hispanic and Latino population. And it is a small population, African American. We're also the highest percentage of the share of the population compared to other locations. So a lot of the work we have been doing is really tracking this every week and saying, based on the county, based on where we are, how are we doing, and what are we doing to increase the percentages of both SVI and racial and ethnic equity. This is one of our SVI tracking pieces where we look at one, of course, is the highest vulnerability, and 0 is the least vulnerable. And then on the left-hand side is the percentages of vaccination. So you can see that actually, and this is a lot of the work that IHS has been doing, but like McKinley County, you can see actually very high SVI and high vaccination rate. You can also see Luna County. They have actually been increasing over time. They have a high SVI, but over time, I think they started really low, like 15%, and they've been increasing over time. So we're able to see, where we need to work on and what locations we need to focus in terms of high social vulnerability populations. This is another data set that we look at as well, looking at vaccine rates for communities with high SVI, and then who had at least one vaccine. So those are kind of ways we've been using mapping to identify. So like if there's one area, so this area here, has a high SVI, and but they've been able to get between 51 and 67% vaccination rate. So you can see we're able to see over time. This map used to be red, and little by little we're getting to blue. And then, like I said, and it's a collective effort, right? A lot of the work here in the Northwest is from IHS doses and work that Dr. Darwin will be talking about later. So using data to inform actions for improving vaccine equity, that was a big piece of the work that we've been doing. And so, like I said, the mapping guides where we place the vaccines and increasing coverage for certain priority groups that we're tracking as well, how we're doing. We're also doing rapid community assessments in the community to inform equity. So this is from the CDC. They have a like standardized questionnaires that you can ask in the community. They're called rapid community assessments that you can then analyze and say, okay, these are the key findings, and then take action on it. So that's what we've been doing at the DOH too. Here's one example. These were a group of community health workers that the New Mexico DOH worked with, and as well as with UNM faculty, family medicine residents, and health policy fellows with our community partners to really be in service to the community by working with the community to say, hey, here's a survey we can do to help identify barriers and facilitators, and then do this survey together. And that's what we did. And together we made it fun and had like a river of life in terms of river for barriers to COVID vaccinations. And so these were some of the key things that they found, like we haven't heard about registration activities. We were worried about side effects, language barriers, can't take time off work. This was actually the one that came from our essential workers interviews of people who are speaking Spanish. They were like, the vaccine site was unfamiliar and far away. There wasn't enough vaccines. They were concerned about immigration. So we were able to collect all that information, and they also then looked at that and said, well, they proposed solutions to us at DOH, like, well, what could we do to support them to make vaccine sites better and more reachable for these groups? So I'm just using one example. So this was with the Mexican consulate and interviewing essential workers who, they had identified in the community. And they said they needed more community outreach, they needed more community vaccine sites, they needed sites with extended hours, they needed to hear that it was free, and that it was also, they had information in Spanish, that the hotline would be in Spanish. So different things like that. And so what we did was we pulled in those assessments as well as assessments done by Presbyterian. We also had done a lot of town halls. So we pulled in all the information and data that we gathered from community assessments, as well as national data that actually seemed to align similarly to what we were finding, and identified, people were concerned about side effects, about safety. They had a lack of trust. They were concerned about cost, insurance, and immigration status. In terms of barriers, they had a lot of difficulties with the registration app, with transportation. Some of them were unclear about vaccination processes and location, and a lack of understandable information. So we took that. We couldn't fix everything immediately, but we've been fixing things over time to try to make it easier for people. So we changed the messaging so that we were really consistent about saying anytime you say COVID vaccines, it's free to you. There's no need for ID, no need for insurance. They also had requested pictures of different ethnic groups, not just one group. So we had different pictures put on our COVID vaccine flyers. And then, I think one of our challenges right now is making sure everybody can get access to these. And that's what our communications team is working on this, so more people can have access to all our materials. The programming, the call center now both registers and schedule people who call the hotline. And I know in the Southwest, they had already been doing this. They had been having community health workers register and help organize events in the Southwest region. The other piece, and I think that's why we were able to see how, like, just as in one example, Doña Ana County started pretty low, and then now they're doing really well because of all the efforts that they've made getting vaccine closer to the community. We've done other things to try to remove barriers. So bringing the vaccine closer to the communities with mobile teams, smaller events and trusted locations, really working with primary care and office-based vaccinations, working with local trusted community partners. And like I said, making the vaccine easier to get evening and weekend or hours. There were some offices that were concerned, like, oh my gosh, I can't open up a second vial of vaccine because they want to use every last dose. And we still encourage people to use every last dose. But if we have to make a decision between vaccinating 4 people and maybe wasting a few doses, right? It's still important to get those 4 people. So we really just want to make sure everybody gets vaccinated. We're also trying to figure out for children 12 to 17 years old, they only can get Pfizer. Pfizer's a lot harder to handle. So we're working on a redistribution plan so that smaller offices can get access to the Pfizer for their smaller kids, for the kids. The other thing that we do is we've really worked on developing alternate hours, nights and weekends. So we're actually contracting with some other companies to try to help us get to these smaller locations. And also our National Guard team has been amazing. They just were like, yeah, we'll help you. We'll do evenings, we'll do weekends, we'll do whatever you need to get to the people. So that's been a really great partnership. These are the mobile teams that the National Guard has been helping with. We call them NET teams, or New Mexico Equity Travel Teams. And then we also have a FEMA mobile unit that's been going to high SVI locations in Albuquerque to try to get vaccine closer to people as well. And, the newest thing that we've been doing is self-scheduling mobile clinics. So now schools, faith-based organizations, work sites, community orgs can fill out an on-site vaccination event request form. And then we're doing that work of matching the providers who can offer mobile vaccine event options with the community orgs. And we're just starting that as well. So all this data that we've been collecting and all the information, it's all leading into us trying to keep on improving things and making things better for populations to receive the vaccine. This just started yesterday. It's the getvaxnewmexico.com on-site vaccination event questionnaire that groups can fill out and ask for a vaccine mobile team. Also, we did registration of the vaccine. People could self-schedule, and that's now open to all New Mexicans. We kind of did it first for seniors, and we moved it down to 40 and up, and now anybody can self-schedule. We have now walk-ins and on-site registration. And then our call center, we ramped up some of our Spanish-speaking call center so that we can make sure people who can't speak English can actually get scheduled as well. I don't know if you knew about this, but this weekend we're partnering with United. For every home game, we're going to have a vaccine event. So we're also trying to say any person who actually gets vaccinated will get 2 tickets to the United event. So we're really trying to do different things to get to people right now. We've also been doing a lot of marketing as well. We've partnered with the tourism department, and so they've developed a series of trusted voices of New Mexicans across the state sharing their experiences and building trust in the vaccine. You can also nominate a colleague to appear in this, but this has been going on for a few months now and very successful. Our marketing department had like different themes throughout the whole time. So like first was like testing in January and starting to introduce the registration tool. Then, we had a big registration push in February, which was get in the game push. Then we had a get the facts push, which was really combating misinformation. And it's your turn. So basically that's when we started self-scheduling. And now we're in May trying to see, we found that the data shows that when you ask your doctor, people tend to get more vaccinated. So that's the next campaign that the marketing team is working on. And here's just some pictures of their marketing materials. And then once again, for the community engagement piece, we know that's slow and it takes time and it takes time to build trust. So we're really working with our current health promotion managers. And we also hired another manager that works with the health promotion managers dedicated really to the equity piece, because that's what we're trying to do with the vaccines. Also trying to increase our network of community health workers so we could get closer to the communities. And then, like I said, working with all the different community orgs, as well as local pharmacies, hospitals, clinics, just really all hands on deck to address how we can get to herd immunity. And then we're really doing a lot of work with just thinking through taking this time about the vaccine equity piece. Really, how are we thinking about this, not just right now, but for the future? So how are we thinking about these partnerships? So kind of organize it into 3 groups of partners that there's a lot of data that shows, in the public health world, that shows that when you start with community priorities, so health councils, faith-based organizations, community-based organizations, people who are on the ground, when you start with those priorities, and then you have government entities that are, so for instance, Department of Health with a health equity policy and programs that support the priorities in the community. And then you have external facilitators like universities or nonprofit all working together, then you can have a more sustainable system for the future. Communities with their bottom-up priorities, governments with like policies that support priorities in like kind of the policy space, and then facilitators who can facilitate that long-term sustainable work. You can have longer-term health equity. So you can kind of see how that's kind of playing out with the vaccine equity here. We have a lot of the information and data we're getting from the communities, from the partners, from community health workers. And then we're really working closely with different federal entities and, around the health policy of equity. And then many community hospitals, clinics, universities, foundations, and nonprofits all pulling in to all work together for long-term equity. So that's our hope, is that with the vaccine equity, we pulled in a lot of people, everyone's working together, let's keep it going. And so we can reach that goal of like 60% of New Mexicans with at least one dose, 48 fully vaccinated, and get to this one goal right now of getting 60% fully vaccinated by June 30th. And this is what we need to get there. We need 8,069 doses per day. There's certain areas like the Southeast that really we need to work more and try to see how we can support them better to see if they can get vaccine. I know there's a lot of reluctance in that area. And then we know that we're slowing down, that there's less and less people wanting vaccines. So how can we continue to, reach out to people so we can increase that doses administered per week? And yeah, and this is where we look to all of you, we've gotten vaccines to those most at risk. This is the White House COVID czar, Jeff Zients, I guess. And he says, we'll continue those efforts, but we know reaching other populations will take time and focus, and I think trust, and so this isn't going to happen overnight. We have to keep on working with all of you, with all the communities, to really slowly build trust and get to that last mile. We know that there's some groups that probably will decide not to get a vaccine, but this group that's very likely or somewhat likely is the group that we're hoping that we can continue to support and get so that we can be safe again in New Mexico. So that's the whole update that we have on vaccine equity. And yeah, would really like to hear from you at this point. Or any questions you have.
Yeah, definitely. I just want to say thank you, Dr. Parajon. As a reminder, if you have any questions for Dr. Parajon, please submit your questions through the session's Q&A tab in Whova, and we will address as many questions as we can during the time allotted. So Dr. Parajon, we have a few questions for you, and some good questions too. So I'll start with question number 1. Okay, so how can we work to move the needle on allowing community health workers back in the community and homes with the COVID precautions preventing this? Okay, did that make sense? And I think you can read it too. So how can we work to move the needle on allowing community health workers back into the community and homes with the COVID precautions preventing this?
So I think that hopefully our community health workers will be getting vaccinated. And so once you are vaccinated, you can go into the homes and you can do home visits. So I will definitely check back in with our epidemiology department. Maybe we just have to be more clear on what a vaccinated person can do. But for sure, if you've been vaccinated, obviously still wear your mask, keep a social distance. But, I think it's okay for community health workers to go back into the homes and do these visits safely, especially if they've been vaccinated. And obviously encourage their families that they're visiting to be vaccinated and answer their questions, right? And one of the things we're going to start next month, we're going to have an open community health worker training sessions where we can share messaging that they can use. And we'll also be giving them updates on what you can and cannot do when you're vaccinated and how to kind of like answer questions. And I think sometimes part of the trust piece, and community health workers are such an important element of all this work. They're trusted by the community. So if the community health worker is a trusted person, can answer people's questions, I think, people will feel better about the safety of the vaccine and be able to more willing to get the vaccine.
Thank you. So next question. Please speak on the Department of Health's plans to vaccinate our teachers now that our children have been going back to school. The news has not given us an accurate information. Are teachers included as essential workers? And if not, why not?
Definitely, they are included as essential workers. Any teacher who wants a vaccine right now will be prioritized in any line to get vaccinated. We prioritize teachers very early on, well, not very early, but in March. So we actually had 80% of all the teachers that we had registered as teachers got vaccinated in the month of March. So that if there are any teachers or people who aren't vaccinated yet as teachers, like please let them know, like sign up on the app, self-schedule. If your school has a lot of people unvaccinated, get on the Get Vax app and we can, organize a mobile team. But right now there's so many locations that have slots that it should be relatively easy for a teacher to get a vaccine. So please get out there and get vaccinated if you're a teacher.
Thank you. So this is more of a theory.
Okay.
So people who have face-to-face contact with their clinical team tend to have better psychosocial outcomes, Do you agree or disagree with this theory, and why?
Okay, that is a good question. I agree. I think that is great to have face-to-face contact. I'm actually don't know the studies or theories on that, but it seems like a correct thing to be. I don't know if anybody else on this call has more studies on that, but it makes sense that having face-to-face contact is more more it's more fulfilling for people.
Thanks.
Yeah, but
Next
I don't know the answer. I'm sorry. I'm supporting you, like who asked the question.
and maybe we can get an answer to that question. So we'll look at that a little bit more
Okay,
and
maybe
post.
someone can chat at the end.
Yeah,
Yeah,
definitely.
there's a lot of skills and knowledge in this group. So
Absolutely, you're right. Okay, so next question, Dr. Parajon. Is there any events going on in Rio Arriba County?
There should be. I'm not really, I don't have the data in front of me, but I can find out. And if you send me your email, if I can send through the email, I can let our team know, ask them where to if there's any events going on in Rio Arriba. If you do not have events in Rio Arriba, please let us know and we can try to organize an event over there. We have teams that can get out there. So like, let's say, I'm just using an example. Let's say, so for instance, Columbus down in the South, um, didn't have any providers near them. And so they asked us for an event and we went back twice, did 250 doses the first time with Johnson & Johnson, and then another 250 doses. So we can definitely get to where you are. If you can organize an event, we'll get there and try to meet your needs. Mhm.
Great. Thanks for the questions. Here's another one. Will there be plans included for booster vaccines for COVID?
Oh, that's a really good question. I mean, I think that has been in the planning. Maybe Dr. Darwin, he's very scientific. He might know more better updates. But what I'm seeing as updates is that yes, it sounds like you'll need another booster, kind of like the flu, every 12 months, just because of the multiple mutations that are going on. If we could vaccinate the whole world and get masks on everybody in terms of social distancing, masking, then I think we wouldn't keep on spreading it and having more variants, because like the more people have it, the more variants can occur. But that's not happening. So many places don't even have the luxury of having vaccines right now. And so look at India, look at Brazil, look at Colombia. There's places around the world that are really continuing to suffer because they don't have vaccine. And so I think we will end up having to have boosters. Mhm.
Thanks. So this is actually a piggyback question on
Okay.
the first question. Is
Okay.
the Department of Health working on policies for community health workers who don't want to be vaccinated to continue working in the community?
That's a very good question. That is the same, I think the community health worker who chooses not to get vaccinated, or the nurse or any kind of healthcare provider that choose not to get vaccinated, basically what we've been recommending is that they continue, they can still see patients with a mask on, and keeping social distancing of 6 feet and just being really careful. But that's the most we can do. People have their reasons for being vaccinated or not being vaccinated. But yeah, if your job requires that you're, for this whole pandemic, for most of it, I was a physician in a shelter, and I still worked, like seeing patients, but I had my mask on, and I had my goggles, and I washed my hands, and just stayed safe. So I think there's those practices that people who choose not to be vaccinated still just need to follow. Mhm. but we can send you more information. We have a containment policy, so I can try to see, they're updating the containment policy. So if you just look up New Mexico DOH containment, COVID containment policy, the latest one will pop up. So I think the last one was, I think it was dated in April, I believe. And so this month, a new one will come up as well, I believe. So yeah. So then just keep in touch with that containment policy, and it'll tell you like what you can do in the workplace, what you can't do if you're vaccinated versus not, you know. And also the CDC website has recommendations as well.
Great, thank you so much. Let me see if there's any more questions. Doesn't look like there's any more questions, so I just want to end by saying thank you, Dr. Parajon, for your time and for your expertise and for everything you're doing for New Mexico. We definitely appreciate all of your efforts towards creating true health equity in New Mexico. I want to thank all of you who have attended our meeting. So thank you to all our attendees for joining us. Please remember to check your event dashboard for more information about our upcoming sessions, including today's presentation on COVID vaccine prioritizing equity by Captain Will Darren from Indian Health Services. So again, thank you, Dr.
Thank you.
Parajon. And we
Thank
just
you
want to
so
say
much.
thank you and
All
have a
right.
great afternoon.